Okay. So I'm just going to share my screen really quickly. Share. As far as the webinar housekeeping is concerned, our objectives here today are to help individual lymphedema patients. Our goal simply is to educate the world, including the public and medical health professionals, that effective treatments for lymphedema do exist. Dr. Chen and I have no financial disclosures. We do not have a financial relationship. Nobody's getting paid to do this. This is on our own volunteer time. We have no doctor-patient relationship. I've never been treated by Dr. Chen and do not plan to do so in the near future. Again, we're just friends or, work community colleagues. This session is for patient education. It is not to be construed as medical advice. And our opinions are our own. I work for a lymphatic nonprofit organization. Today I'm wearing my patient hat. I'm not speaking for that organization. And it's just me on my own as a patient advocate based on my own personal experiences. And I'm sure Dr. Chen will say the same. When we do get to the names in the Q&A, because the session is being recorded, your name will not be disclosed. So don't feel like you need to shy away from asking questions because your name will not be disclosed in the session. So I'm going to hand it over to Dr. Chen now, and we'll get started.
Okay, Fern, if you can enable sharing screen so I can share my screen. All right, well, Vern is working on allowing me to share the screen. Good morning, everyone. And I understand that this time can be quite early for some of you on the West Coast. But I'm very happy to be here. And I want to thank Vern for this opportunity. The reason, well, as Vern said, none of us is being paid to do this, but we want to do this because even if I see patients nonstop in my clinic, operating nonstop during my in my work, there's only so many of you that we can reach. There's only so many of you we can help. And even in my clinic, I usually can't explain and deliver information as well as I can here with the help of ability to show you pictures and videos. So I think a lot of suffering from lymphedema in patients is number one, the anxiety of unknown, the anxiety of not knowing what your doctors and therapists can do for you, and the misinformation that there's not a whole lot that can be done for lymphedema. And so that's the main goal that I would like to achieve today, is to deliver information that you can use and to let you know that lymphedema is treatable. Usually people don't get freaked out with high blood pressure, cholesterol, or even diabetes, even though some of these conditions are much more, I think they are a bigger problem potentially than lymphedema. But usually people don't freak out over these conditions because they know that their doctors know what to do. All right, without further ado, let's get started. Okay, now I can share my screen. Okay, so In this talk, I'm going to share with you what are the newest in lymphedema surgery. And I call it as of current state of the art in lymphedema surgery as of 2023, because this is a field that is rapidly advancing. And so by next year, chances are we will have something newer and better. So stay hopeful. Even as of today, we can already deliver, for most patients, quite effective treatment. But I do believe that tomorrow we will do even better. If you've been researching in the field of lymphedema surgery, then you know that there are different opinions. So in this talk, I will try to deliver to you first of all, what are the treatment options when it comes to lymphedema surgery? And then what do most surgeons think? And what do we think? How do we approach lymphedema surgery? And I will need to tread carefully myself because there are different opinions. And so when I will try to be careful that when there are things that have been proven by studies, high quality investigative studies, I will let you know that this is something that has been proven. If this is something that is still controversial, that surgeons disagree, I will let you know as well. All right, let's go ahead and get started. No disclosure. These are all the procedures that are currently available, going from the bottom to the top. You see down there radical excision, also called the Charles procedure, going all the way up to the top. Distally based delayed LVA, and another name for it is lympha, or the preventive prophylactic LVA. So going from bottom to the top, you can see that, and also look at the date on the second column from the right. Those are the dates when these techniques were discovered or described or published in the literature. You can see that over time, these procedures are becoming progressively less and less invasive. And also the indication for surgery, the reason that we do these procedures also went from waiting until lymphedema gets really bad. For example, for Charles' procedure, we waited until patient gets to fulminant disease, elephantiasis. Then we treated with a radical, morbid, highly invasive procedure, the Charles procedure, to the DDLVA or lympha that we are trying to prevent lymphedema from happening altogether. And so you can see the trend that also reflects our advancement. We're getting to lymphedema earlier and earlier and with better and better results. And if you look at the LVA, lymphatic venular anastomosis, lymph node to vein anastomosis, LNVA, vascularized lymph vessel transplant, VLVT, and vascularized lymph node transplant, VLNT. I labeled them 1, 2, 3, and 4. So all four procedures treat fluid disease, or the fluid predominant form of lymphedema. As many of you know, that lymphedema in its earlier stages tend to be mostly fluid. In its earliest phase, it can be all fluid. But fairly quickly, lymphedema starts to cause deposition of abnormal tissues. Lymphedema-associated fatty tissue, fatty deposit, as well as scarring. We call it fibrosis, fibrotic tissue deposit. So deposition of abnormal fatty tissue and fibrosis are the solid components of lymphedema. So these four procedures, LVA, LMVA, VLVT, and VLNT, all treat fluid disease. So surgeons have started thinking about, do we need four procedures to all treat the same problem? Shouldn't we just find the best procedure and perform that one single best procedure? And if so, which one of these four is the best procedure? So I want you to take a look at these four procedures: VLNT, VLVT, LNVA, and LVA. Yeah, all these abbreviations. Look at the dates when they were discovered. VLNT from 1990, to the most recent LMDA 2021. And think about that question. Shouldn't we just find one that's the best and do just that single procedure? Or should we continue to do all four of them? All right, so I'm going to quickly provide you with an overview so you have a general understanding of all of these procedures, some of the indications, contraindications, and some of the considerations related to these procedures. So starting out with the Charles procedure, you can see at the right lower bottom when Dr. Charles was with us, and it was in the last century. Actually, Dr. Charles was born in the 1800s. And the Charles procedure is still occasionally needed, even as of today in 21st century. But I'm happy to report to you that we uncommonly need to perform this procedure. In general, due to improved patient and physician education, and patients are being much better informed, patients are coming in seeking treatment earlier. So we fortunately don't need to perform this invasive and morbid procedure too often. So I see that as a sign of progress. And you can see right here, this is a fairly disfiguring, but sometimes necessary procedure. It does treat lymphedema effectively, but it does so at a cost. Lymph node transplant, I think many of you are familiar, and maybe even some of you have had this procedure done. This is what I call the robbing Peter to pay Paul technique. This is also the technique that I started out doing when I started treating lymphedema quite a while back. This was the only technique that I performed. So originally, it started out as groin lymph node transplant. So we would take lymph node from the groin and transfer it to the arm or leg or whichever part of the body that's being affected by lymphedema. And over time, as surgeons became aware of the possibility of creating problem at the donor site, we started to explore different parts of the body. Where else can we take lymph nodes from? Where else, which site is the safest? And which site would still give us sufficient number of lymph nodes? And therefore, all these techniques were developed. We've started harvesting lymph node from the chin, from the chest, from above the collarbone, from even inside the abdomen, as you probably have heard the old mental lymph node transfer, or taking it from the small bowel, the mesenteric jejunal lymph node transfer. But regardless of where you take the lymph node from, the principles are the same. It's robbing Peter to pay Paul. It's borrowing from, well, actually not borrowing, it's robbing. We're taking from another part of the body. We are injuring another part of the body to treat in order to treat the part of the body that's affected by lymphedema. And we're hoping that the donor site is robust and strong enough lymphatically to tolerate that injury. So here is the consensus by most surgeons. Most surgeons would agree that lymph node transfer does work, and it works through the mechanisms of lymphangiogenesis and the so-called pump mechanism. And most people believe that more lymph nodes means that this transfer will work better. And most surgeons also would agree that taking some skin along with the lymph node will work better, and harvesting more skin will result in higher surgical efficacy. And when the skin is included, we need to respect its axiality. That means the direction of drainage, direction of the lymph drainage. And what's still controversial among the lymph node transfer surgeons are the recipient site. Do we do proximal transfer? So let's say when we treat arm lymphedema, do we place the lymph node in the armpit? Do we place it at the wrist? Or do we place it at the elbow? So where do we place the transfer lymph node, the recipient site? And also there's still debate about which lymph node donor site is the best. And it's also now commonly recognized that if the patient already has what we call solid predominant disease, then lymph node transfer isn't very good at treating that. It doesn't treat the lymphedema of fat and fibrosis. So here's our take. We agree that lymph node transfer does work. However, we feel that even though lymph node transfer was a state-of-the-art technique when it was initially created in 1990, that as of today, it no longer is the most advanced technique. And as I put there, like iPhone 1, remember when iPhone 1 came out in 2007, it was state-of-the-art. Everybody, no one had touch screen, and iPhone 1 had touch screen. But as of today, now we're on iPhone 15. So even though iPhone 1 was state-of-the-art, it was incredibly advanced, but as of today, it's already obsolete. And also, we have evidence to indicate that lymph nodes are bystanders. They're not the actual therapeutic components of a lymph node transfer flap. So what are the actual therapeutic components? What are the things that make lymph node transfer work? In our opinion, lymph vessels are the actual therapeutic components. If you think about what pumps, lymph nodes don't pump, lymph vessels pump. So as I said, lymph node transfer, one important drawback of lymph node transfer is that it necessitates injury, creating lymphatic injury in another part of the body that may not be necessary based on what are available today. There are other treatment options available. And another key disadvantage, in our opinion, is that it causes disfigurement. The lymph node transfer does create lymph node flap has its own bulk. And lymphedema is a problem of both function and appearance. And the appearance problem is bulk. So when you treat a problem of bulk by adding even more bulk, to us, that is a problem. And as you can see in the picture on the slide, that we transplanted the lymph node transfer flap to this patient's wrist. This was a very successful case in terms of treating the patient's functional problem. This patient had lots of swelling, pain, tightness, rigidity, heaviness. All of those symptoms were relieved. However, in terms of the appearance, as you can see, it doesn't look very good. Lymph vessel transplant. This technique was pioneered initially by Professor Isao Koshima, and then later on, we also developed our techniques of lymph vessel transplant. Dr. Koshima created the foot-based lymph vessel transplant, and we created the groin and chest-based lymph vessel transplant, treating the arm lymphedema with the groin-based lymph vessel transplant and treating leg lymphedema with chest-based lymph vessel transplant. So I call this procedure, we're still robbing Peter, but we're robbing Peter a bit less because we're now sparing all of the lymph nodes. If you look at that picture on the left-hand side, you will see that regardless of the donor sites, this is the usual anatomy. The lymph nodes are usually situated in the deep fat layer, whereas in both superficial and deep fat layers, you will find an abundance of lymph channels. So if you harvest the flap superficially, sparing the entire deep fat layer, you will be able to spare all the lymph nodes and therefore decreasing the amount of injury to the donor site and therefore decreasing the risk of creating problem at the donor site. So this is the consensus by most surgeons that number one, it probably works, and it probably works because currently from other surgeons, there's a little bit too limited an experience to conclude whether it works or not. And however, we have seen experienced lymph node transfer surgeons worldwide starting to trial this technique. And I think it makes sense. They've been performing lymph node transplant. They have seen the good and bad of the lymph node transplant technique. Now they're looking for something a bit more refined, and they're looking to try to decrease the donor site morbidities. And lymph vessel transplant is an obvious evolution following lymph node transplant. The downside, one major downside of the technique is that it does require supermicrosurgery because the vessels are usually smaller than what encountered in lymph node transplant. So for lymph node transplant, it's mostly a microsurgical procedure. Lymph vessel transplant frequently is supermicrosurgical, and therefore it is more appropriate for experienced lymphedema surgeons. You can see the benefit right there in the pictures. The inset is completely flat because we harvested a very thin flap, and therefore the inset is flat as well. There's no more bulge. So our take on the lymph vessel transplant is that it definitely works. In our experience, it works just like lymph node transplant without any perceived observable difference. And that's because, as I said, the therapeutic component in lymph node transplant has always been lymph vessels, not lymph nodes to begin with. And therefore, when you transfer the lymph vessels, when you transfer an abundance of lymph vessels, it should still work. And it does cause less injuries. How do we know that? We know that by always studying the donor site after surgery using indocyanine grain lymphography. That's how we can visualize the injuries, and that's also how we can compare the severity of injuries following lymph node transfer versus injury following lymph vessel transfer. And therefore, we do consider this technique superior to lymph node transfer. It works the same, it causes less injury. We consider it the lymph node transfer 2.0. And earlier in my practice, the lymph vessel transplant had completely replaced lymph node transplant. The drawbacks, in our opinion, is it still necessary? Because LVA would achieve similar results in the hands of experienced supermicrosurgeons. So LVA would do the same thing as lymph vessel transplant. So do we still need to rob Peter at all? We probably don't need to anymore. Number two, as I said, it requires supermicrosurgery. Number three, it still causes lymphatic injury, even though it causes milder injury. It does still cause injury. We're still hurting another part of the patient's body. And therefore, in our opinion, we feel that lymph vessel transplant would be appropriate for lymph node transplant surgeons who are now experienced and they're looking for a more refined, less invasive technique. And lymph vessel transplant is still appropriate as a rescue procedure if LVA that was initially offered to the patient is not successful or is not working to our satisfaction, then lymph vessel transplant can still be considered. Okay, LVA. So I think most people are familiar with LVA. LVA is supermicrosurgery, and LVA is minimally invasive. You can see in the pictures, usually we make multiple small inch-long or inch-and-a-half incision on the leg or arm, and we get in there. We identify functioning lymph channels, and we find veins to connect them to. And so these channels are really tiny, and the procedure is performed under high-power surgical microscope. The sutures we used are nearly invisible to naked eyes, and these sutures are definitely way smaller than hair, as well as the needle that you see right there in the video is smaller than our hair. So LVA is the supermicrosurgery. It works by connecting lymph channels to veins. And so most surgeons would agree that LVA works, but only works in early disease. So this is such a long-held dogma, but it's recently starting to be challenged. So more and more are starting to see that it may also work in advanced disease, not necessarily restricting its indication to early lymphedema. And most would agree that LVA should be part of a lymphedema surgeon's armamentarium. Now most surgeons would agree that one shouldn't be a one-trick pony, and one shouldn't have a hammer and nail approach to try to treat everybody with a single technique. So what we're still lacking consensus in are where to make incision, how to best connect a lymph channel and vein. Is it end to end, end to side to side to end? So there's still debate about that. And how many connections are needed? How to determine surgical success? How do you know the surgery has worked? And also its therapeutic role in primary versus secondary lymphedema. So there are several considerations when it comes to deciding which procedure would be appropriate. And it is relevant to consider whether the patient has primary, in addition to considering the severity of lymphedema, it's also important to consider whether the patient has primary or secondary lymphedema. When there is time during Q&A, I'm happy to discuss about that. So our take on the LVA is that it works really well in all fluid diseases, regardless of severity, whether it's early, whether it's late, whether it's severe lymphatic injury or mild injury, LVA works. As long as the patient are still in the fluid predominant phase, the LVA works. And this is great news because LVA is the least invasive procedure of all. And it also works well, equally well, in both primary or congenital lymphedema and acquired or secondary lymphedema. There's more to be said about that, but it's equally applicable to both primary and secondary lymphedema. So just like lymph node transfer and lymph vessel transfer, it still does not treat fat and fibrosis. So it only treats fluid, it doesn't treat fat and fibrosis. And nowadays, well, there was a time that incision planning, where to place the incision, there's a lot of uncertainty. And surgeons need to rely on their knowledge of lymphatic anatomy a lot. But that's no longer the case. Now we have a lot of technologies that help us identify where the lymph channels are, identify where the veins are, and not only identifying where the lymph channels are, identifying where along this same lymph channel it would be the most beneficial for us to create an LVA. For example, we can see the obstruction, we can see the flow problem. So we could follow a lymph channels, we can follow its flow until we get to a point of obstruction, and we can strategically place the LVA at that spot to create the most effect. And when it comes to how do we bring them together, which anastomotic configuration would make the most sense, we recommend doing the freestyle LVA, which means that you do whatever anastomotic configuration that makes the most sense given the situation. For example, if you have a tiny lymph channel, you have a big vein, then you would anastomose the end of the lymph channel to the side of the vein. So that's our take. Do what makes the most sense given the situation. And as far as the quantity of LVA, it should be inversely proportional to lymph vessel quality. The higher the quality of the lymph vessel, the stronger that LVA is, the less you would need to do. And the opposite is also true. If you're treating a patient with fairly advanced lymphatic injury, then you may want to do more LVAs to compensate for the lack of quality with quantity. And ICG lymphography is very helpful in determining surgical success. We recommend that all patients get a baseline ICG study to document where they are, undergo treatment regardless of the type of surgery, and then undergoing further ICG study at different time points. For us, we repeat the study at 3 months, 6 months, 1 year out from surgery, and then following that once a year. And that's how we know that LVA works progressively. LVA works immediately and then progressively over time. In our observation, most patients would demonstrate continuous improvement for 1 to 2 years following surgery, which means that following a successful LVA, the patient may not be seeing full benefit until 2 years out, although the patient should feel a difference, should feel a benefit fairly early after surgery, sometimes even next morning. Occasionally, even on the table, we see the improvement already. Lastly, LVA, among all these procedures, in our opinion, is the most nuanced procedure, and it requires a lot of cases for the surgeon to get over the learning curve and achieve proficiency. So yeah, that's our take on this procedure. A very powerful, highly effective procedure, but does require surgeon experience. So this study just came out of Japan from Professor Sakoshima's group. Basically, what it's telling you is that LVA is not a simple plumbing procedure. So many people, including surgeons, mistakenly think that LVA is plumbing. There's lymphatic obstruction, so we do bypass procedure. Many people also call LVA a bypass, implying that we're bypassing an obstruction. So that's not entirely true. As it turned out, in lymphedema, there is a decrease in T cell diversity. Well, that's an immune cells. As you know, there are B cells and T cells and various other immune cells. A decrease in T cell diversity is not favorable. And in lymphedema patient, as you can imagine, there's increase in inflammation and therefore increase in inflammatory mediators. There's also increase in exhaustion mediators. Many patients feel that they have a lack of energy. They always feel exhausted. Following LVA, these disturbances were either normalized or significantly improved. Following successful LVA, the researchers have found that there was increased T cell diversity, decrease in inflammation, and also decreased exhaustion mediators. So the effects of LVA is not simple plumbing. There's a lot more chemical reactions that happen in the background. All right, the prevention surgery, or the so-called LYMPHA. It stands for Lymphatic Microsurgical Preventive Healing Approach. So now, collectively, we are doing pretty well in terms of treating established lymphedema. Now surgeons are working on trying to nip lymphedema in its bud. So the credit should go to Dr. Campisi Senior, and Campisi Junior, as well as Dr. Feldman out of Columbia, New York. So the technique was initially pioneered by the Campisis, and then Dr. Feldman in New York picked up the technique and investigated it further and published their initially favorable results. And the technique has since then gained traction in US and in around the world. Many surgeons started to offer this procedure, most commonly immediately following breast cancer treatment, after the breast surgeon, the oncologic surgeon, removed the lymph node in the armpit. Lymphedema surgeon would come in and reconnect the severed lymphatic channels. That's essentially the Lympha technique. So we took the Lympha technique, we modify it because in our opinions, there were some drawbacks with the original Lympha technique. So our version is the DDLVA, distally based delayed LVA, that's performed in the elbow instead of in the armpit. It's also not performed at the same time as the cancer surgery. And there are several different benefits of the DDLVA in our opinion. And if you're interested, you can find a study which is available online. One of the major benefits is that the LVA is performed after radiation has been delivered and outside of the field of radiation, and therefore we don't need to worry about the LVA being damaged, as opposed to the classic Lympha technique. So over the years, most surgeons follow the classic Campisi-Feldman Lympha technique, and very few perform our recommended DDLVA. So Campisi-Feldman technique has been the mainstream technique with much fewer following our teaching, our recommendation. Earlier this year, just back in February, Dr. Feldman's group published their long-term study. So they were following all of these patients, excuse me, who underwent lympha technique. And their conclusion is that, unfortunately, and to a lot of surgeons' disappointment and patients' disappointment, they didn't find that lympha technique was helpful, that it actually didn't show patient having had lympha technique did better than the control group in which the patient did not receive the lympha technique. So the lympha technique was declared an unsuccessful technique, an unsuccessful attempt to stop lymphedema from developing. So consensus, I think as of now, surgeons are pondering and thinking, reflecting over Feldman's finding. And since this is a procedure that is now widely accepted and widely performed, definitely further investigation is needed to explore and demonstrate, is this technique, so what Dr. Feldman found, was it applicable only to his group, or that is a reflection of the technique not working? Okay, debulking liposuction. So this is due to the finding that lymphedema is not just lymphedema. Lymphedema is not just a fluid swelling problem. Lymphedema causes actual deposition of abnormal fatty tissue and fibrosis. And when it comes to lymphedema liposuction, Dr. Håkan Brorsson out of Sweden should be given credit to pioneering the technique. The classic Brorsson technique involves performing dry liposuction, which means not using a medicated fluid called tumescent solution. Involves the use of a tourniquet to help decrease blood loss. And Dr. Brorsson recommends to not remove any skin excess, and also no need to treat the foot and hand, because Dr. Brorsson felt that these areas typically have mostly fluid disease. And also, it's very difficult to maintain surgical benefit, even if the surgeon treated foot and hand, because these areas are characteristically difficult to compress, as many of you have experienced firsthand. So our version of lymphedema liposuction is Matisse, stands for minimally invasive tissue excision with possible skin excision, or the nickname flying squirrel technique. And there are several key differences. First of all, we aim to normalize, which means very aggressive removal of abnormal tissues. We also recommend doing wet liposuction using tumescent solution in addition to tourniquet to further decrease blood loss. And we do recommend treating foot and hand, because for many patients, they have dorsal hump. They have this hump on the top of their hand and the top of their foot, which create lots of morbidities. And we do recommend removal of skin excess when there is clearly too much skin excess, because the skin excess, as we know, does not completely go away. So here's the consensus that liposuction, most surgeons would agree that liposuction is effective, and that liposuction effectively treats the solid disease component. And most of us would agree that proper patient selection is important, meaning you want to offer this procedure to patient with solid disease. You don't want to offer this procedure to treat fluid disease. As I said, majority of the surgeons as of today do follow Dr. Brorson's teaching, and which means that they believe that the skin excess would completely resolve itself. And to us, that is a conceptual paradox, because from experience, we all know that if we lose a lot of weight, or if I'm a woman and I have 3 babies, my abdominal skin doesn't completely shrink back down, and therefore plastic surgeons would do a tummy tuck. Or if I lost a lot of weight, I may have hanging skin under my arm because the skin doesn't completely retract. So our take is that liposuction is incredibly helpful. In fact, we consider it the most underutilized, underperformed procedure. And in our practice, we do see quite a few patients who've already had lymphedema surgery performed from outside institution, and for various reasons, the results were not the most satisfactory and therefore requiring a redo surgery. From what we have seen, the most common reason for a redo is when the patient really would have, when liposuction would have been the most appropriate procedure for the patient, but instead an LVA or lymph node transplant was performed. That is what we see most commonly, the reason for a patient needing a redo, and that is when they really would have benefited from liposuction the most and a physiologic reconstructive procedure was performed. So liposuction is underutilized. And the best outcome in our experience is obtained through aggressive, thorough removal of abnormal tissues. But as you can imagine, aggressive surgery also means the risk of complication go up. So the surgeon certainly needs to take a carefully balance between the aggressiveness, the thoroughness of the surgery with safety. A very careful balance, delicate balance is needed. And skin excision should be selective. We don't recommend universal removal of skin, but at the same time, we also don't recommend that the surgeons universally not remove skin. Of course, the surgery is only as good as proper patient selection. Even if you take the best surgical procedure, but you offer it to the wrong patient, of course, the surgery is doomed to fail. We don't recommend universal skin reduction, but it should be selectively offered in patients who would benefit from it. And lastly, this is counterintuitive, and including some surgeons would mistakenly think that liposuction causes worsening of lymph drainage. This is something that has been proven, and hopefully our study will come out soon, is that liposuction actually, not only that it doesn't worsen lymph drainage, it paradoxically improves lymph drainage. This is great. This is great news because it means that it serves dual purposes. It removes abnormal tissues, and at the same time, it improves lymph drainage. We're currently looking into how. We've already proven that it does improve lymph drainage, as you can see on the ICG imaging on the left-hand side. You can see before and after and how the patient's ICG lymphography improved. So we know that it consistently improves lymph drainage, but now we're looking into how, why would it improve? And as of today, we don't know the mechanism, but we do know that it improves lymph drainage, which is great. So hybrid approach, this is our own unique approach, which means that we perform debulking liposuction or Matisse first, and then we perform LVA or LMVA, which I will talk about in a little bit later. So debulking first, reconstruction later. Why this particular sequence when more surgeons would do it the other way around? They would do reconstruction first, LVA, LMVA, or lymph node transfer or lymph vessel transfer first, and then liposuction later. We recommend the reverse sequence. The reason is what I have just shown you, that liposuction would create this almost obligatory post-liposuction improved lymph drainage. So as I've just said, LVA works better when you are performing the procedure using high quality lymphatics. And therefore, performing liposuction first would allow you to develop healthier lymph channels, and therefore LVA is expected to work better. So this is a case that we have just performed the LVA portion. And so this patient, you can see prior to liposuction on the left-hand side, this patient was wearing a flat knit class 4 garment. And despite wearing a demanding garment, she already developed many infections of her left arm. We performed liposuction, removed 2,700 cc. You can see now she had a skinny arm. It was equally skinny compared to her right arm. She only had a single episode of infection during 2 years after her liposuction, and she was able to, and it was a mild episode instead of the serious infection that she used to get. And she was able to go to a lighter circular knit class 3 garments. And on the right-hand side, you can see this is the same patient. 2 years after liposuction, now with regenerated lymphatics, we went ahead and performed the LVA. So what we found during the LVA case is that this patient demonstrated lymph channels that were so healthy, so strong, that they were completely unexpected for someone who initially required liposuction. So we just performed the LVA on this patient a few weeks ago. She's still early in her post-op course, but I fully expect that this patient would do very well, just given how strong her lymph channels were. So this is another patient that we have just recently performed her LVA. You can see that prior to liposuction, she was wearing a demanding garment. And on top of that, she still had to wrap on top of her garment. Following liposuction, we removed 4,300 cc. She actually increased her compression effort because, well, not that she was doing worse now, but because now this patient understood what constitutes proper management. And she has seen how nice her leg and thigh are now looking. She really wanted to do everything she could to maintain her surgical outcome. You can see the three-dimensional volume scanning on her post-liposuction picture, that her left lower extremity is now already smaller compared to her right lower extremity. 13,855 cc versus 13,910 cc. And then we moved forward with her LVA procedure. Again, she was now 2 years out following her liposuction. And again, we found lymph channels that were so healthy that was unexpected of someone who required liposuction procedure. And you can see how nice and strong these lymph channels are. Again, this patient is still early in her post-op course following LVA, but we do fully expect that she would do very well. And we await to see her when she comes back for her 3-month follow-up. Another patient, this patient we had longer follow-up prior to liposuction, class 4 flat knit. After liposuction, class 3 circular. And then LVA, this was her 6 months out following LVA. She was able to go to a class 1 circular garment compared to initially she was on a flat 4 down to class 1 circular. And this is another patient who had the hybrid reconstruction, but here I want to show you how quickly an LVA would work. Just pay attention to this patient's ankle. You can see how much more visible her ankle bone was. And this procedure lasted about 3.5 to 4 hours. In just 3.5 to 4 hours, her leg was significantly reduced while the patient was still on the table. All right, lastly, lymph node to vein anastomosis. This is our latest technical innovation. We started to offer this procedure now a year and 3 months ago. So we started offering this procedure last year in 2022. This procedure was originally created by a Polish surgeon in the 60s, but due to various technical reasons, it didn't work quite well. And in 2021, it was enhanced and modified by Professor J.P. Hong's group, Dr. John Peck being the lead investigator. And we took Professor Hong's technique and we modified it further by introducing high-frequency ultrasound evaluation of the lymph node. And this way we can select the healthiest, the most functioning lymph node in the groin region. And we also introduced tagging or targeting using a radar system that you can see right there. We place a tiny radar reflector called Savvy Scout reflector that is smaller than a grain of rice to the top of the lymph node, which help us getting to the lymph node rapidly and with minimal disturbance to the lymph node. And therefore, we're able to preserve the most function of that lymph node. So this technique, as I said, so far, we're over a year into our experience of this new technique. And so far, it's what we have seen is quite promising. And we think that this technique has the potential of being LVA 2.0. So far, we are performing it in conjunction, most commonly in conjunction with LVA to achieve the most benefit for our patients. On this video, you can see how the reflector helps us locate a lymph node. In the video, is showing the reflector being used to detect breast cancer, but we use it to detect the lymph node. Here's the demonstration of the LMDA. You can see a lymph node that's already uncovered. And then we take a needle to poke a hole to create an opening in the lymph node. Now you will see lymph immediately pour out. That's how we know this is a highly functioning, healthy lymph node. And we already knew this procedure would work very well because this lymph node is highly functioning. And then we connect a vein to that opening of the lymph node, and therefore this is LMVA, connecting a lymph node to vein anastomosis, lymph node to vein anastomosis. And therefore this node then start to drain into the vein. All right, finally putting everything together. So this was our initial protocol. We would treat patient with stage 0 disease, patient who had already sustained lymphatic injury, but were not symptomatic for lymphedema yet with DDLVA. And we would perform LVA and later on LMVA for early fluid predominant disease and lymph node transfer for late fluid predominant disease, liposuction for solid predominant disease, and Charles procedure for fulminant disease. And then as of 2017, we replaced lymph node transfer with lymph vessel transplant. We found that lymph node transplant really was not necessary. And then we realized that LVA, especially in combination with LMVA, are incredibly powerful, and that really further decreased the indication to do lymph vessel transplant. We don't need to do lymph vessel transplant too frequently anymore. And then we realized that liposuction really has been so underutilized. Really, a lot more patients would have benefited from liposuction instead of lymph vessel transplant. And therefore, the indication for lymph vessel transplant has been even further reduced. In fact, in the past 2 years, we haven't had to resort to lymph vessel transplant yet. We speculate that lymph vessel transplant may become obsolete, even though as of today, it's still on our protocol. Lastly, the hybrid approach can be offered to further improve surgical outcomes following liposuction Matisse, which usually is already highly favorable, but we can go back and offer the patient LVA and or LMVA, as well as lymph vessel transplant very, very uncommonly to further improve the patient's condition. Lastly, is lymphedema cure a clinical reality? Yes, as of today, it is a clinical reality. This is a paper that we have been submitting now for 7 years, And finally, as of 2 months ago, it was finally accepted. So now the surgical community finally recognized that lymphedema cure is achievable, but we are achieving it uncommonly, or much less commonly as we would like. But at least now we recognize that lymphedema cure is a reality, and we need to investigate. We need to investigate how we can achieve it more consistently and how we can extend this favorable outcome to more patients. That's all I have. I ended up taking a lot more time than I had hoped. My apologies. My intention is to leave time in abundance, time for question, but all right. Well, thank you for your attention. So if we still have time for question, I'm happy to take any questions that you may have.
Dr. Chen, you have about 10 questions in the Q&A right now. I think we'll go for about 15 minutes, and then if you need to take a break or stop there, then we can do so. Is that okay with you?
Yes, I have all morning blocked out for this. So you can take more than 15 minutes.
Okay. First question is, what are the guidelines for candidacy? How bad do you have to be? This patient gave additional details about a personal story, but I think those are common questions. How bad is bad? Do you have to be to consider?
As you've seen, that we're operating on patients who are not even symptomatic for lymphedema yet. So you don't need to have bad lymphedema to consider surgery. So instead of considering surgery as a second-line treatment, I would recommend that you consider surgery as a treatment option, along with lymphedema therapy, which is a non-surgical treatment option. So these are two treatment options, surgical and non-surgical. They have their pros and cons. They have their indications and contraindications. And my recommendation for all patients is become informed. And that's why you're here. Become informed, know your options, and then decide what treatment option works better for you. We're all different. We have individual considerations and conditions.
Second question. I have pubic abdominal lymphedema caused by pelvic lymph nodes taken from cancer surgery. Are there any surgeries to correct this?
Yes, there are several different treatment approaches. First of all, if the problem is inside the pelvis, say, for example, from ovarian cancer, uterine cancer, or cervical cancer, we know that not only the abdomen, not only the genitalia, but frequently the thighs and legs and buttocks are also affected. So there are many different procedures that can't be applied to treat this condition. But frequently we start, if patients are also symptomatic in their legs, we usually would advise treating the leg first. Despite the symptom in the abdomen, usually the leg would progress faster and progress to a stage of disease that's more severe. And decompressing peripherally, decompressing in the leg, will also help decompressing the abdomen and pubic region. So there are many different ways to treat this and different combinations. And with the procedures that I have talked about, and the specific sequence and choice of procedures, there's a lot more to consider that depends on individual patient's condition.
Have you found that ultrasound is an effective enough way to determine the best lymph node for LNVA surgery?
So that is under investigation, but preliminarily, yes, it's certainly helpful. So there are characteristics of lymph nodes, so healthy lymph nodes versus problematic, compromised, or even non-functioning lymph nodes. They demonstrate certain sonographic characteristics. So by looking at them using ultrasound, it helps us. But this is certainly a work in progress. But preliminarily, we can say that it is certainly helpful.
This is a very common question. I think that this question has come up every time we've actually met, and this is our third iteration together. Why is BMI so important to have surgery with you or to even be seen? I've lost 300 pounds and can't do any more to get my BMI below 30. It is so disheartening.
So the short answer is that for patients who are heavy and they're interested in, they want to treat lymphedema, weight loss is an incredibly effective way to treat lymphedema. So when the BMI is elevated, so there are actually two levels of consideration. Number one is surgical safety. Is it safe to do surgery? And that is not just lymphedema surgery. When a BMI is significantly elevated, the risk of complications go up. That goes across all types of surgery, not just lymphedema surgery. The second is when the BMI is elevated, is our surgery, not only that it's unsafe, is it even going to be effective? So that's the second consideration. Several of these procedures, as you have heard, involves redirecting the flow into the venous system. When the patients are heavy, usually the venous system is also not working too well. So is it going to be effective when we redirect the flow to the venous system? So surgery may not work and surgery may not be as effective. Now, surgery is serious. Surgery is invasive treatment. So we need to approach surgery seriously. If we're going to do it, we want to make sure that we do it and that it's a home run, that it works great. Not just that, we're not too sure whether it will work or not, but we're going to go ahead and do it and see what happens. So, and number three is, as I've just said, losing weight, becoming lighter would take the load off our lymphatic system. So when the BMI is significantly elevated, all lymphedema patients are advised to work on weight loss, not just to become a surgical candidate, not just to make their surgery safer and more effective, but also to treat their lymphedema. So I understand that this is a sensitive topic. Therefore, many healthcare providers avoid the topic, and they understand that this is the easiest way to alienate themselves from the patients. Frequently, when this topic is brought up, people are unhappy. But I feel that as a healthcare provider, we're not entertainer. We're not here to please. We're here to help you. So if we are not sharing with you what you need to know so you can start to help yourself, we're not doing our job. So those are the reasons why decreasing BMI is important. And achieving a lean body composition is very helpful in managing lymphedema.
Next question. What is your opinion on sclerotherapy to stop lymph leaking in the scrotum area? The swelling in the area is not bad, but the skin is so thin in that area that it's prone to leak through the skin.
So yes, we do see this a lot. So in male patient, it could be leakage, lymph leakage through scrotal region, penile region. In female, it's their labia, genitalia. Sometimes leakage can happen in the groin region or even lower down in the leg. So all of these conditions, and the leaked lymph fluid could be clear or it could be milky, depending on the fatty content. So all of these conditions are reflecting an underlying lymphatic hypertension. So the lymphatic system is under a lot of pressure. So it's trying to decompress itself. It's trying to leak and decompress this high pressure system. So trying to treat these conditions from the skin level, cutting these lesions out or cauterizing them, or they tend to not really, well, they are not addressing the root of the problem. They may temporize, but they're not addressing the root of the problem. The way to treat these problems is to reconstruct the lymphatic system and not to cut out the cutaneous manifestations. Compression does help in this situation. So the rule of thumb when it comes to compression is to compress any part of the body that is swollen.
Okay, so this person is, or attendee is a parent, and he has the follow-up question. This sclerotherapy procedure on my new son, 16 years old, has been done once 2 years ago and 1 month ago. So far, the second procedure has made it leak more. We are planning to head back and be reassessed for the next steps. Would you recommend something to be done in the future? I think you already answered that question.
As I said, addressing the cutaneous manifestation is not addressing the root of the problem. So rebuilding the lymphatics, let's say, for example, LVA or LMDA in the groin or LVA in the suprapubic region can help with the situation.
The next question is a super common question that we see in the Lymphie Strong group. Do you still need to work with your therapist for MLD along with the compression after surgery? I think this is a top question that
So
very often.
think of it this way, as I said, non-surgical treatment and surgical treatments are treatment options. Surgery will work with or without MLD and compression. However, in conjunction, they definitely work better. So it's not that you need to do those non-surgical treatment in order for surgery to work, but they certainly help surgery work even better. Or you want to think of it as surgery help MLD and compression work even better, whichever way you want to think of it. We do recommend continuing MLD and continuing compression. And as long as we haven't cured you, you unfortunately would still require to do what all lymphedema patients would need to do, which is keeping up with the compression. However, a well-maintained lymphedema condition on a light compression garment is obviously quite different than poorly managed situation and still requiring multiple layers of demanding firm, flat-knit compression.
It's sort of the message that we try to convey when we get people who are newly diagnosed and like just started swelling. Take care of it now, because I remember when I used to be able to wear a 15 mercury garment, and now I have to wear class 2. You know, so much easier with the over-the-counter than it is with custom. Next question. What does a patient have to do post Matisse to help get the hybrid stage for surgery? What is the timing for the next surgery? What is the realistic recovery for LNVA? Thank you very much for sharing this information so clearly.
Okay, so the question is, how long after Matisse do we need to wait before we do LVA or LNVA? So that depends on, first of all, the first question the patient should ask themselves is, are they satisfied with the results obtained through Matisse? I would say usually for arm, the results are already quite satisfactory. Frequently, patients are able to wean down to a fairly light garment at 1 year out or so. And definitely at 2 years out, many are wearing a fairly light garment. Remember that I said post-liposuction Matisse, we see progressive improving lymph drainage. And as their lymph drainage improves, they usually are able to wean to a lighter, less demanding garment. So that's the first question. Am I satisfied or unsatisfied with my results right now? If I'm unsatisfied, am I dissatisfied enough that I want additional surgery? If the answer is yes, then we consider more surgery. Then the next question is, we know that liposuction Matisse stimulates this progressive improvement. Has there been sufficient improvement achieved that we should move forward with the LVA? What is the best timing for LVA? That obviously would be when the patient has done most of the improvement after Matisse. For some, they achieve that state at 6 months out. For some, it's 1 year out. For some, it's 2 years out. In the case examples that I showed, two patients were both 2 years out following Matisse. But that varies. That varies. But I recommend proceeding with that sequence of thought process.
Next
And
question.
the recovery for LMDA, there's minimal recovery. It's LMDA involves making a about 2-inch or 3-inch long incision in the groin. It can also be performed for arm lymphedema. For arm lymphedema, it would be at the elbow, targeting the elbow lymph nodes. And recovery is a month of compression and a lot of elevation. But in terms of pain, there's minimal pain.
Next question. In LNVA surgery, does the lymph node try to heal itself over time, which could jeopardize the connection you made?
And lymph node heal over time and jeopardize the connection we made. I'm not too sure what that question means. I guess you're asking whether the connection was shut down over time. So far, what we have seen is, so LMVA can not work. And when the LVA isn't successful, it's usually because the lymph node is already too functionally compromised, that it doesn't drain well. What we have seen is that in all cases, when we had healthy lymph nodes, the procedure works great. But as I mentioned, this is a renewal or rekindling of an old procedure. And so far, our experience is about a year and 4 months. What we can say is so far, our experience is highly favorable. We, of course, are still investigating, and we will report back to you and the communities around the world when we have further findings.
The next question is a very popular question in the community, not just with you, but other surgeons that people go to. I'm having Matisse with Dr. Chen in December. Is there anything in particular that I should do to best prepare?
So many patients feel that we need to see their worst condition to evaluate them. It's actually quite the opposite. We always want to evaluate our patient in their best condition. And in fact, leaving your leg or arm swollen, well, here, I'll make it simple. I think the overarching goal when it comes to lymphedema management is to keep your affected part of the body free of swelling at all time, not just occasionally you achieve the state of no swelling. We recommend that all patients maintaining their affected part of the body free of swelling at all time. So if you keep that in mind, then you would have answers to many of your own questions. For example, what type of compression garment should I be wearing? Well, you should be wearing the easiest garment that would still maintain your arm and leg properly without swelling. So if you wear a circular 3 garment, you have swelling, that means you probably should go up. You probably need to try a higher, stronger circular or switching to flat knit. And the question of how much should I be wearing compression garments? Should I wear nighttime compression? Well, do you swell? Do you wake up in the morning with swelling? If you wake up in the morning with swelling, you probably would benefit from nighttime compression. So we want our patient to maintain their affected parts of the body free of swelling at all time. The reason why this is important is you don't want your leg or arm or other parts of the body to be bathing in this inflammatory fluid. It causes tissue injury. It causes worsening of disease.
The next person didn't leave a question, just comment. Amazing talk, Professor. Greetings from Mexico.
Oh, thank you. Thank you. I know we have some microsurgeons in the audience, and well, thank you guys for coming. And well, I thank you for helping lymphedema patients in your parts of the world. There definitely need more of us around the world. And you can see here how many patients would benefit from your contribution, your help. This is definitely one of the most underserved patient population. And yeah, thank you.
Next question. What is the recovery time for Matisse surgery and what are the restrictions?
Matisse for arm, thigh, and leg are all different. The most demanding would be Matisse of the leg. And in general, how demanding the recovery is proportional in direct relationship to the severity of disease, in particular, the severity of fibrosis. So because of our aggressive and thorough approach, our technique tends to create quite a bit of neuropathic discomfort, the burning sensation, the stabbing, tingling, numbness during the recovery period. And that, depending on the patient, can last for a few weeks to a few months. But over time, everybody got better. And I would say vast majority of the patients are very happy with their results. But for some, particularly for patients who had leg Matisse, the recovery can be quite demanding. And they may be requiring medication for their neuropathic discomfort. So we usually can predict who would have a tough time, and we try to prep the patient. But still, sometimes the recovery is quite challenging. That is something that patients should know. Arm, almost always the recovery is fairly straightforward. Thigh is fairly straightforward. Leg is the challenging one.
I'm thinking of my own legs when you say that. Next question. Is there a time limit on how many years out from onset of lymphedema, which is reasonable to consider surgery?
So the duration of disease is frequently people interpret duration of disease as severity of disease. That's not quite a one-to-one relationship, even though commonly that is the case, but certainly not always. We definitely have seen patients who had lymphedema for decades, and yet they're so well maintained that their condition remained mild. So it's not always just because you've had it for a long time that you have bad disease. It doesn't work like that. And I'm sorry, what's the other question?
Oh, just how long, what's a reasonable time that I guess the question was, is there a time limit to when you can consider
There isn't a time limit.
5,
There
10
isn't a
years,
time limit.
20 years? Yeah.
So the reason to consider surgery, actually, for someone having a solid predominant disease, I think surgery, I think, of course, non-surgical treatment can still be relied upon, although when a patient has solid predominant disease, I'm starting to lean more towards surgery because no amount of compression will get rid of these abnormal tissues. Compression treats fluid. Compression does not treat solid tissues.
Next one is a comment. Thank you very much for your generous time and thorough explanations. Thank you, Veronica, for organizing. You're incredibly devoted. We thank you too for attending. You know, I often say, people often wonder, well, are you going to record it? Where are you going to record it? I hesitate to record because number one, people don't. I feel, in my experience, people don't participate if they feel like they're going to be recorded. But on the other hand, you know, if no one shows up to these things, then Dr. Chen and I are just staring at each other, and I can call him ask him any question that I want. I think, you know, so this really is for the people, for the community, and all of you being here today, asking these phenomenal questions drives the needle forward, because when you ask a question, you stimulate others. They may have the same question. They may ask another question on top of that. And that's how we get these discussions moving forward. So thank you very much for that comment.
So before I answer more questions, I do want to, again, re-emphasize, I've said it in the beginning, but I'll say it again, that you've heard, I try to inform you the hot topics today and the controversies among surgeons. And so as you've heard that there are different opinions, and what you have heard today may be different than what your surgeons are telling you. If you're ready, have a surgeon. And so, by the way, as of today, all of the lymphedema surgeons worldwide have my utmost respect. Even though we may disagree with one another, lymphedema surgery is some of the most challenging surgery, and it's underappreciated. It's under-reimbursed. You may be wondering how come there's so few of us. I can tell you, at least from what I've seen, it's only partially because it's very complicated surgery. A lot more reason is because it's under-reimbursed. So very frequently, surgeons would do surgery and not get paid, or the hospitals don't get paid, or get paid at a level that hospital consider not worth their while. So this situation needs to get better. And all the surgeons who, despite this adverse situation and still are trying their best to help patients, they have my utmost respect. So I've told you our differences, the controversies. My recommendation would be, so it may turn out that we are wrong. And as I've said, we are surgeon scientists. We continue to conduct investigations and research. And in science, we always need to maintain humility and recognize that we may be wrong. But we do try our best to help you. And we do try our best to bring you the best state-of-the-art treatments. But so yeah, that's what I want to say, that as of today, because of the nature of the field, this is a novel field. There are different opinions. So talk to your surgeon, ask a lot of questions, like what you're doing right now, ask a lot of why. And we will tell you, oh, we don't know. This is hasn't been investigated yet. You're asking the same questions that we are asking ourselves, but we are looking into it. Or, oh, it's been investigated, and we know that is the case. Like what I just said, following liposuction, we have seen consistent obligatory regeneration. Actually, to be accurate, we don't know whether it's regeneration. We know we see improved lymph drainage post liposuction.
I think that's why you and I get along so well, because I believe philosophically, if you won't do it, who will? And if we don't ask for it, who will? I mean, there's a patient clinician, bond there that we have to join together and try to push these things forward, with the insurances, the hospital, even our government, at some levels. Okay, so we are at an hour and 30 minutes. What I'll probably do with the video is break it up to cut down the length. Do you want to keep going, or we have 22 open questions now?
Yeah, that would I can keep going. I would suggest maybe the lecture and the Q&A portions could be broken up, and for the video, I think that would be helpful for patients also.
Yes, yeah, I'll break that up. Okay, let's keep going. For those of us with post-secondary lower extremity 36 inguinal nodes excised and 30 days radiation, what is the best option with slightly higher than threshold for surgery BMI?
Why is the threshold for surgery higher for what procedure?
What is the best option with a slightly higher than threshold for surgery BMI? I guess
I'm sorry, I'm still not getting the question.
I guess if you're a little bit heavy or a little bit over the BMI, is there a particular surgery you would start with versus others?
So I think of all the surgery, the liposuction Matisse is the less affected in terms of surgical efficacy because it doesn't bypass, it's not relying on the venous system. But my recommendation is, as I've said, I think the weight loss is again a topic that people have been avoiding, but to the detriment of lymphedema patients. I think patients should understand that is one thing they can do that is highly effective. So I will think of it this way. So we will forget about the swelling of the muscle compartments for now and lymphedema. We'll just focus on what most people recognize, the fluid swelling they can see and feel. Those are superficial swelling or swelling fluid in the fatty space. So you can think of it this way, lymphedema, or at least a superficial swelling, is fluid in the fatty space. So the more fat layers you have, the thicker the fat layer, the bigger the tank you're providing lymphedema with. And therefore, the worse the swelling. And also, the more fatty tissue you have, the thicker the fat layer, the more you will resist compression. The less effective your compression will be, and the stronger your compression will need to be to try to push the fluid out. It's almost like a wet Nerf football that's left out in the rain. Now it's soak up all the fluid, it's soaking up all the water, and you just can't squeeze the fluid out. And therefore, thinning out the fat layer would have the opposite beneficial effect. You're shrinking the tank, you're improving your responsiveness to compression. Everything gets better. So most commonly, our BMI cutoff is at BMI 30. That's out of consideration for surgical safety. But let's say a patient who's been working on weight loss and she's doing incredibly well. She came back and said, I'm at BMI 28 now, but I'm still losing weight. I'm doing great. I'm doing intermittent fasting and eating healthy and working out. I would tell that patient, let's not rush you to the operating room. You're still getting better. You're becoming an even better surgical candidate. And actually, I'm not worried about the patient worsening during that time that she is working on weight loss because her lymphedema is also improving at the same time. So far, 100% of our patients who have successfully lost weight came back and told me that their lymphedema had become a lot better without fail, 100% of the time. Even our surgery isn't as successful. We don't have a 100% success rate. But weight loss so far in our observation, 100% success rate of improving lymphedema. So why not?
I'm just going to put in my own personal experience. I was considering a surgery in the abdominal, completely unrelated to lymphedema. And I had a surgeon tell me that exact same thing. I was thin at the time, but he said, you know, before you have the surgery, you really need to have a strong core. So if you're working out and you're doing all these things, I would postpone for a few months if you can get your core stronger, and then we can do the surgery. So, I mean, just case to your point, you know, that had nothing to do with lymphedema. I think that's a very good answer. Okay. Oh, this is another popular question. Well, two questions. Following LVA, can you then now have LNVA? And is wearing compression garments following surgery always going to continue, or will one get to the point of no longer needing them?
Okay, well, I think the question is essentially asking whether we can cure. So compression garment won't be needed if we cure. But as I said, we are curing uncommonly. So our rate of achieving cure based on our study from quite a while back was 16%. I know that our cure rate as of today here at Cleveland Clinic is actually a lot lower, substantially lower. Not because that our treatment efficacy has gone down, actually quite the opposite. Our treatment efficacy had gone up a lot. But I know for a fact that our cure rate has gone down, mostly because we are now receiving some of the most challenging cases from around the world. And we're treating a lot more primary lymphedema patients than acquired lymphedema patients. We're now treating a lot more primary leg than acquired arm. So these two are the polar opposites in terms of prognosis and the challenge of treatment. So, and therefore our cure rate has gone down. But one thing that I've noticed that's interesting is no one really would go to their doctor and say, I want you to cure me of my high blood pressure. I want you to cure me of diabetes. Even though, as I said in the beginning, these conditions are equally bad and these conditions can kill, can be life-threatening. But we're not really all that afraid of them because we know that there are effective treatments. And I think lymphedema is no different. I don't think our treatments for lymphedema are any less effective than treatment of high blood pressure or diabetes. In fact, we're doing a lot more for lymphedema than we are for these conditions. So I think sometimes patients ask about cure because they are just anxious. They are under the impression that there's not a whole lot that can be done. They want to get out of this condition. They want to be cured. But in fact, I think many are looking for effective treatment. If they can be reassured that effective treatments are available, that they can continue to live a relatively comfortable and productive life, they won't be as fearful.
I've been a patient advocate for 8 years or over 8 years now. I've met one person who I can say has been cured. This woman was a dance teacher who got breast cancer, survived breast cancer, and she was so meticulous. She shared her whole story to an inpatient support group that I used to lead. But she did exercise. She followed a very rigorous diet. She, wore all her garments. It took her 3 years, but she achieved it, and her arm was so beautiful. And then, of course, she resumed her dance teacher, profession. But even at that, as a dance teacher, you know, you're always moving. So that's like exercise all day, basically. It's the when I saw that, I saw how hard, you know, it would have to take. It would have to take like complete devotion. Uh, anyway, that's just my personal experience. Next question. I am a CLT. How can we get our patients a consultation with a qualified surgeon like you? Do you have a wait list?
So there are qualified surgeons. There are more and more qualified surgeons across the country. More surgeons are joining us. They're hearing our plea that this is an underserved patient population. So we're glad to see that more surgeons are interested in helping. So I would recommend, well, most of the lymphedema surgeons are at major medical centers. So initially seek out, inquire, call up your local major medical center. Of course, if you're in Cleveland, Cleveland Clinic, if you're in Ohio State University, major medical centers tend to have lymphedema surgery expertise. For us, we do have a wait list. Our surgery for the time being, now this change all the time. We schedule out about 5-6 months. Our diagnostic testing schedules out about 2 months. That's where we are now. We're constantly working on improving our quality of care. We are expanding. We're trying to recruit more lymphedema surgeons. And we are also working on educating surgeons, training surgeons worldwide, so that we can collectively get better. And we're teaching others. We're also learning from others as well. So as I said, the field is rapidly evolving. And in terms of seeking out expertise, start out with your local surgeons, major medical centers.
So I can actually answer that question. I want to verify that everybody saw that chat that I just posted. Learn, putting my Learn hat on. Learn has a website at lymphaticnetwork.org. The site is called the Centers of Excellence. Cleveland Clinic is a center of excellence where Dr. Chen works, and there are 60 sites from around the world. You know, Campisi, some of the other individuals that Dr. Chen mentioned are on the Centers of Excellence site. So that is a great place to start if you're looking for surgery, is check the Learn Centers of Excellence. Look for, you know, the town or the country nearest you and start from there. Okay, how can patients help support the different hospitals where these surgeries are taking place as advocates in order to get increased resources into these places? And how can we do the same for the purpose of insurance?
So I think to help yourself and help others, you need to make your voices heard. You need to let the communities, the hospitals, your legislators, let people know that you deserve treatment. And your treatment isn't just lymphedema therapy. Your treatment would include the options to seek surgery. So lymphedema patients deserve to be treated properly, deserves medical attention. So I think lymphedema therapy is a component of lymphedema treatment. It's not all of it. So the short answer is make your voices heard. And that would let people know, let hospitals know that if they don't have a lymphedema treatment department or division, or they don't have lymphedema treatment expertise, they are deficient. They need to work on getting that set up. They need to support their lymphedema professionals better. And that would also prompt insurance to start to cover more regularly these treatments that are so much needed by the patients. We see it all the time that patients were kept away from the very treatments they need because of insurance difficulties. And it shouldn't be that way. Every lymphedema patient case for us here at Cleveland Clinic is an insurance battle, every case. And it shouldn't be that way. I spent a significant amount of my time talking to insurance, doing insurance peer-to-peer. It shouldn't be that way. Really, yeah. So I think make your voices heard, let people know that you deserve proper treatment.
I also have an answer to that question. Going back to the Learn Centers of Excellence, if you email coe@lymphaticnetwork.org, if you've had surgery at a Centers of Excellence like Cleveland Clinic or the Boston Lymphatic Center or Ohio State University or Stanford, you can email Learn and say that you want to volunteer for the patient affiliate board. Where you can, as a patient, can volunteer your time to ensure that these programs stay alive and that you have a voice in the matter as to how those programs are being developed for future patients to have the opportunity. And it's at that same link that I just shared with everyone. Next one, what type of rehabilitation do you recommend? Before surgery, diet, exercise, CDT, purchase new garments right before surgery, or wait until afterward to purchase remeasure for garments?
I think we talked about this question already. It's basically maintaining, well, doing your best of what you're supposed to do regularly for your lymphedema management is the best preparation for surgery.
Next one is not a question, but rather thank you. So generous of you to share your time and expertise with us. Thank you. You addressed pelvic lymphedema. Is it possible for primary lymphedema that invades the torso to do LVA in the torso?
Yes, most definitely. We've mentioned in our studies, and I think we are coming out with a study focus on this very subject, that primary lymphedema is systemic, which means that even if a patient with primary lymphedema only has swelling in her left leg, the entire body is affected. And in fact, the left leg is the most common presenting symptoms for patients with primary lymphedema. About 70% in our database of patients with primary lymphedema initially develop symptoms in their left leg. Usually the second place to develop symptoms is then the other leg or right leg, the contralateral leg. And then the condition can progress to the rest of the body, or in patients who are more fortunate, their symptoms remain limited to only a part of the body, and most commonly left leg. So treatment of primary lymphedema, depending on, first of all, which procedure would be the most appropriate? Let's say if it's LVA, where should the LVA be constructed? That depends on a lot of consideration. It depends on where the patient is symptomatic and also what are the deficiencies. What do the deficiencies look like in the rest of the body? So it's actually quite an involved consideration and planning. So I won't go into the detail, but it's not necessarily LVA swelling in the trunk, then we do LVA in the trunk. But in answer to your question, LVA certainly can be performed in the trunk.
Next question. You have mentioned in the past that many CLTs are not well versed in most current therapy techniques. What do you believe is the best resource for CLTs currently?
So no, that is an inaccurate statement. So what I said is currently there is no well-developed post-surgical therapy
Yeah.
There is none. So therapists are well trained in general in what they do, which is to manage non-surgical lymphedema patients. After surgery, and depending on the surgical procedure that the patient had, their physiology and pathophysiologies have changed. I think lymphedema therapists, and on this, I urge all lymphedema therapy schools, the leaders of lymphedema therapy schools, to reach out to surgeons and partner with us to come up with lymphedema therapy maneuvers and treatments that are designed specifically for lymphedema surgical patient. For example, MLD of the arm is always pushing towards the armpit. But if I build a powerful LVA in the middle of the forearm, should you push towards that LVA or should you push towards the armpit? There's a lot of consideration there. If you're closer to that LVA, you can push to that LVA. That is the closest point. So a lot of things change following surgery, and I think the lymphedema therapy can evolve as well to create something called post-surgical lymphedema therapy or pre-surgical to optimize the patient, to get the patient into their best condition prior to surgery. Doing so, obviously, would facilitate surgery, but also to allow the patient to see what the best non-surgical treatment can achieve. So they can be in a better position to consider, do I really want surgery? Is this not good enough? Is the best therapy not good enough? So very commonly when patient sought surgery, they really haven't achieved the best of what non-surgical treatment can achieve. So actually in their individual situations, it's not that lymphedema therapy has failed. It was, they just haven't achieved, they haven't been optimized through therapy yet. So it would be quite helpful that patient can see what the best therapy can achieve before they consider surgery.
Does LNVA get better over time like LVA?
So we do, as I said, our follow-up is now just over a year, but from what we have seen, yes. So the two procedures are very similar in the sense that both involve connecting lymphatic tissues to veins. Both procedures connect lymphatic system to venous system. And we do expect, and so far we've seen that LMVA should behave just like LVA. The difference is that LVA drains individual lymph channel, while LMVA drains an entire lymphosome, provided that the lymph can get up to the lymph node. Then that lymph node would drain all the lymph channels in that lymphosome. That's the major difference between the two procedures.
Next question, is ICG test helpful? Okay. Is ICG testing helpful or important if you aren't having surgery? I've only had lymphoscintigraphy. What additional information would change treatment?
So people have different practices. In our practice, we do feel that ICG lymphography is incredibly important in tracking disease. So comparing, let's say, a patient's condition this year and last year, even if the patient felt no outward differences, patient feels subjectively that everything seems to feel the same. What about their lymphatic system underneath? Is it really unchanged? So ICG lymphography can detect subtle, minor disease progression or improvement despite the patient feeling absolutely nothing. On the other hand, if the patient feels better or worse, are they truly improving or are they truly worsening? So how we are feeling are symptoms, but how are they truly doing will require visualizing their lymphatic system. So in our opinion, yes, ICG lymphography is an incredibly important tracking tool tracking study, regardless of whether the patient is interested in seeking surgery or not?
This one is a little bit long. Good morning from Sulphur, Louisiana. At the time of my lymph node dissection mastectomy, I underwent a LVB2 vessel. I still develop lymphedema. My physician has never done follow-up imaging despite my inquiries. How can I politely insist that follow-up images be done? Is follow-up testing necessary? Surgery was January of 2021, followed by chemo and radiation. And then she has a second question. Is there research underway that uses stem cells to develop lymph node vessel for implantation and treatment of lymphedema? That's a long one.
So as far as can you twist your surgeon's hand to do something he or she doesn't want to do, the answer is unlikely. But I think certainly you can have an open discussion with the surgeon, why or why not. Listen to his or her rationale. And if you still are interested in getting imaging studies done to bring clarity to your condition, you certainly can go to another practitioner, another provider who offers the imaging study. As I said, in our opinion, it is helpful to know, to see patients' lymphatic system, and in terms of establishing a trend, whether the patient is improving or worsening, that obviously requires more than one imaging study. That require two study points. A baseline study today and a future study, say 6 months later, and compare the study results, compare how the patient's lymphatic system look. Do they look the same? Are they improving? Are they worsening? So that all provides valuable information. As far as whether there are the people studying lymphatic regeneration, whether it's stem cells or placing some conduits, yes, there are people studying all that, and both stem cells and placing conduits to stimulate lymphatic regeneration. All those studies are being conducted. But I think we certainly are hopeful that things may get worked out that are even less invasive than what we're currently doing. But I would say what we are currently doing are already effective, and we are working on making them even more effective. So when it comes to deciding whether one should undergo treatment today or undergoing a specific treatment, we should always think about, just given how rapidly the field is evolving, I think the situation is a bit similar that you're about to purchase a new car and you're thinking, should I wait for next year's model or should I go ahead and buy it now? Tesla's becoming cheaper and cheaper. They're making another price cut. Should I buy now or should I wait for their next model? Maybe the new model is coming out. Yeah, it's kind of similar to that. And especially with how rapidly we are advancing, that is a valid consideration. With newer treatment that comes out that makes the best treatment today looking not so good anymore. I think, yeah, that's we don't know what we don't know. And that is certainly a risk. Even though a treatment we may be wholeheartedly endorsing and recommend today, we may later on find out that no, we were wrong. Just like how we were wrong about carbohydrates. At one time, we're telling everybody to eat tons of carbs, eat a low-fat diet, and eat tons of carbs. That was in the 90s. And now we're telling you the opposite. So yeah, I think that is just a realistic risk of modern medicine, that we are still advancing and we don't know what we don't know.
Okay, we are at the 2-hour mark. And Dr. Chen, I'm gonna stop recording here. And if you would, oh wait, let me stop recording. Where's the recorder?
Let's see. I don't know where you are in the Q&A. Let's see. Should I start from the bottom or the top? Okay, I'll just start from the top. Joining from Canada, does having liposuction mean wearing garment for the rest of your life? Actually, quite the opposite. As I said, having lymphedema requires wearing garment. And liposuction procedure very frequently would decrease the demand of compression, meaning we're following liposuction due to eliminating these abnormal tissues and due to improved lymph drainage. Patients are usually very commonly able to wear a lighter garment, and if they were having infection, usually they would stop having infection or would develop infection much less frequently, and the infection usually becomes a lot more mild than prior to surgery. How effective are pumps in controlling swelling? So pneumatic compression pump is an area of active study that we are currently undertaking. So preliminarily, we find that pneumatic compression is helpful. But helpful, what's the best way to administer it? What's the setting? How high should the compression pressure be? All of these are lacking high quality evidence that we are currently actively investigating. We should be able to get back to you soon. I would say in a year or two, we should have much more definitive answer on how to use this useful modality that patient can administer at home. To clarify my question, I meant to say, well, looks like I'm reading the questions in reverse. This is a question about lymph node to vein that we poke a hole in the lymph node. Does that close up over time as lymph node tries to heal itself? Okay. We haven't seen that, although we certainly are continuing to follow all of our patients. Okay. So we have one of our patients who just had Matisse 4 weeks ago. Okay, I hope that you're doing well. This patient is sharing that I won't say it has been super easy 4 weeks, but to everyone considering this procedure, it's very worth it. Okay, I'm glad that you feel that way. So it sounds like you have it in your leg. So as I said, that tends to be the most challenging recovery. And I'm glad that you feel that it's worth it. If you feel that it's worth it, you're at 4 weeks out, I think you'll be really happy later on. Several years later, after developing lymphedema, I'm having foot drop symptoms. PCP suggests an EMG, but I'm nervous to do so. What is your opinion? So, lymphedema does not cause foot drop. Foot drop is most commonly from patient being very diligent with elevation, and also from the patient when they do stand on their feet, they're not bearing full weight, and therefore the flexor muscles or their calf muscles are really strong. It causes foreshortening of the Achilles tendon. So that's foot drop. So very commonly this happens, as I said, patients who are overzealous with elevation and are not stretching their Achilles tendon. And I think proper diagnosis is important, even though I speculated that is the cause. EMG that looks at your muscle. By the way, as Vern has said in the beginning, we are not supposed to diagnose and dispense medical advice on this forum. So I need to speak on hypothetical terms, and this should not construe as medical advice. But in generally speaking, with or without lymphedema, proper, accurate diagnosis before starting treatment is needed. So, yeah, so we're not against EMG in patients with lymphedema in general. How soon, generally speaking, can one resume physical activity after Matisse surgery? Swimming. So take it easy for a month following not just Matisse, but most of our lymphatic reconstruction surgery. Speaking to solid disease in leg, if your weight fluctuates 5 to 10 pounds, does that fat collect more to the lymph predominant fat? So weight fluctuation of 5 to 10 pounds, that indicate that there's still a lot of fluid component to the disease, but accumulation of 10 pounds of fluid, that tells us that there may be some accumulation of lymphedema fat. So I think your question is whether lymph fluid turns into fat. Our current understanding is that fluid does not turn into fat. However, lymphedema condition does seem to stimulate these progenitor stem cells that differentiate to become fat, and these are abnormal lymphedema fat. But it's not that lymph fluid becomes fat. They stimulate differentiation of progenitor cells to become fatty cells. You mentioned neuropathic pain following Matisse, burning, stabbing. Can you please explain what is done during surgery that is causing this pain? So it's not that, so any liposuction would, of course, cause disturbance to these minor cutaneous superficial sensory nerves. And that's any liposuction, of course. The more thorough you are in removing these abnormal tissues, the more shock and stress we could be causing these sensory nerves. So these sensations are usually part of the recovery. And actually, when patients are getting these sensations, unpleasant sensation, their nerves are coming back. And sometimes there can be, so in a way, these are nerve healing. And sometimes there can be too much nerve healing, creating hypersensitivity. That's when we heal too much. So not enough or too much healing, they're both bad. It's not that anything in particular that was done to hurt the nerves during the surgery. It's just because of the aggressive nature of the surgery that created these unpleasant sensation. I mentioned medication. Most have a risk of increasing swelling. So, medication for neuropathic discomfort, all medications have their side effect, and side effect is not necessarily bad. And having side effect doesn't mean that you can't take the medication. It depends on whether the symptoms, whether the indication justify the risks or the side effects of the medication. For example, I'm blanking out on Rogaine. I should know this.
Cymbalta and
So it's an antihypertensive. It's a blood pressure medication, but the side effect is hair growth. So if you don't want to grow more hair, that is an undesirable side effect. But if you have receding hairline, hey, that's a great medication. It treats your blood pressure and it helps with hair growth. So it's not to say that neuropathic medication is bad. It depends on whether it's justifiable or not. So should we expect an LVA to break down or age over time? Can the connection last a lifetime? So we haven't seen patients who initially responded to LVA and then worsen. What we tend to see is patient improve for varying amount of time post LVA, which is mostly 1 to 2 years. The longest progressive improvement that we've seen following lymphatic reconstruction was 6 years progressive improvement. We haven't seen anyone who worsened later on. We have seen LVA not working, failing. but we haven't seen the worsening. So I think the answer to your question is an indirect no, but we of course are still following our patients. We don't discharge our patients, although our patients tend to fade off 3-4 years out. Because lymphedema have become a small part of their life. They don't care about us anymore. I do encourage all of our patients. If you're doing very well, yes, that's incredible. But coming back would still provide us with valuable long-term information, data, and that would allow us to answer questions such as this. Does a patient worsen later on, 5 years, 10 years down the road? So I do encourage long-term follow-up. Have you done any or many surgery to stop lymph leaking in the scrotum? I was told my son does not have any lymph node in the groin area. So these are two questions. Yes, we've done, we don't do that frequently, just specifically in the groin to stop the leaf linkage. But over time, since we've been doing this for a while, we've done many for this indication. And the second question, not having lymph node in the groin areas. Yes, that's possible, especially in primary lymphedema. But if they perform a lymphoscintigraphy and not seeing any lymph node, that doesn't mean that a patient does not have lymph node. That simply means there might be unfavorable pressure gradient resulting in the lymphatic system not picking up the technetium 99 or the tracer used in lymphoscintigraphy. So a proper ultrasound study of the groin can identify whether one has or doesn't have lymph node. In general, in acquired lymphedema patient, it's uncommon to not find any lymph nodes. We could be finding fairly compromised lymph nodes, but nearly everybody would have some lymph nodes in the groin. In primary lymphedema, that can be the case. Sometimes we do see primary lymphedema patient having no lymph nodes. But as I said, an ultrasound study would give you the answer.
We're almost done. I'm back if you need me to take back over.
Okay. Next is just a comment. Your presentation has been helpful. Great. I'm glad. And following LVA, can you now have LMDA? Asking again, as it wasn't answered initially. Yes, you certainly can. So following LVA, but by the way, I think the most relevant question, following LVA, can one have LMDA? Probably the more relevant question is, how did that LVA work? Why would a patient consider more surgery? Was it because the LVA didn't work? If the LVA didn't work, it's important that the surgeon analyze why the LVA didn't work. Was it because the LVAs were working, but simply because we didn't do enough, we didn't build enough LVA, that's why it didn't work? Or was it that the surgery just failed altogether? Sometimes, despite functioning LVA, that the LVAs were doing their jobs, but patient just simply had too much of a functional deficit that we need to create more LVAs. Or maybe there was a surgeon's technical problem at the surgeon's end that the LVAs were simply not working. So what was the problem? And also, where were the symptoms? Is it more in the leg, the foot, ankle, or is it more in the abdomen? All these are relevant questions to consider whether one should repeat to do more surgery. And if more surgery is indicated, is it repeating the LVA or is it performing LMDA or maybe even something else? Then that's a transplant. In reference to insurance, don't give up. Yes, I agree. Don't give up. Insurance should do the right thing. I had to submit several appeals to get my surgery approved. Dr. Chen wrote a letter of necessity. Okay, that helped a lot. Keep at it. Have faith and all lymph warriors. Okay. All right. In addition to lymph massage, what are your thoughts on whether regular massage could help fibrotic tissues until Lymphie surgery. So MLD helps with fluid. Here I have a little bit of different opinion from most of my lymphedema therapist colleague. So I think many therapists do feel that their maneuvers would break up fibrotic tissues and allowing them to remove fibrotic tissues. I think it may be difficult just because many of these fibrotic tissues are so dense and so rigid that we need to cut out when we have access to them. We cut them out with a scalpel, and you know how sharp the scalpels are. These tissues are so stubborn, so rigid, they dull our scalpel. After cutting it for a few swipes, it dulls our scalpel. So I'm a bit doubtful that gentle maneuvers from MLD can break up these fibrotic tissues. Of course, as I said, we are scientists. We keep an open mind. I hope that what they do can break up the fibrotic tissues, but for now, I haven't seen definitive proofs. But what they do can certainly treat the fluid disease and prevent further deposition of abnormal tissues. Okay, I think that's it. Have I left out anyone?
Yeah,
Hopefully
for
this
that.
question isn't out of line, but if the drug being developed, okay, I like the challenging question. Okay, hopefully this question isn't out of line, but if the drug being developed at Stanford proves beneficial, could the drug be used in conjunction with surgery to treat lymphedema? Of course. I think we welcome Dr. Roxon's work, and we hope that it works out. When one day we have a pill for lymphedema, that's when I may be able to stop doing lymphatic surgery. And I'm a plastic surgeon. Maybe when that day comes, I start my cosmetic surgery practice. But I think the reality is many of our patients can't wait. As we are waiting, their conditions are worsening. They're already developing stage 3 disease. They're developing frequent infection. And lymphedema for these patients have already gone from being a minor inconvenience and appearance problem to now a life-threatening problem. So we do look forward to further advancement in medicine, and we hope that one day there is a pill that our lymphedema patients can take and their condition is treated. But until that day happens, we try to do our best to help. Okay, I think that is it. We've done it, Vern.
Did you get the age limit?
The age limit.
Yes.
Oh, age limit on no. So as you all know, nowadays people are living longer and longer. Life expectancy has increased. And I think it becomes even more important that we don't just live long, that we live a long and happy life, productive life. So our oldest patient was in her 88. I remember 88 because 88 is a good number in Asian tradition. So age doesn't preclude surgical indication. I mean, they're really frail 40-year-old and they're really healthy 80-year-old. So it really age alone, age does certainly is a consideration. As we get older, we have less physiologic reserves, but age alone doesn't preclude a patient from surgery.
You got one final answer. I mean, final question. Can
Would you
LVA
do LVA and LVA at the same time? Okay, so yes, in the very beginning when we started offering LMVA, we did, but we realized that that's not the best approach, as these are extremely delicate procedure, and both LVA and LMVA require a lot of the surgeon's best effort. So each procedure takes anywhere from 3 4.5 to 5 hours. So as you can imagine, if we were to do 2 supermicro procedures back to back, we're not giving our patient our best. And that's why here at Cleveland Clinic, we schedule, at least in my practice, I always only schedule 1 supermicrosurgery case a day. I don't schedule 2 supermicro in a day, exactly for that reason. Not fair to the second patient. We want to do our surgery. We want to do it once. We want to hit a home run and just do it well. We want to offer our patient with the highest quality of surgery. And so the answer to your question is no, we don't do LMVA and LVA simultaneously together due to consideration for the quality of surgery. So we did in the early experience, but now we have learned from our experience.
You answered 44 questions.
Okay.
So
all right. Well, I hope this is helpful to everybody. And by the way, thank you, Vern, for doing this. And please do continue to do this and invite more surgeons, more lymphologists onto your platform and share their opinions. I think all of us are happy to share our experience and what we know, what we have seen. And lastly, to all the patients, stay hopeful. We do know, actually, I will say what I have shared with you is compared to what we know about lymphedema is tip of an iceberg. We do know a thing or two about lymphedema, but until these informations are peer reviewed, we can't responsibly share with you. But many of what I haven't shared with you are favorable. I think if you know what we know, you won't feel as bad about lymphedema as you probably do right now. It's a treatable condition. So don't feel that no one can help you. We are here to help. And there are many more of us from around the world. And thank you again, Vern, for the opportunity.
amazing, amazing, amazing. Thank you so much. To those of you still with us, thank you for staying the entire time. This event will be uploaded to YouTube very soon. Subscribe to Lymphie Strong on YouTube, and then you'll get a notification that it's up. Thank you, Dr. Chen, and thank you to everyone who participated. Take care. Bye-bye.